So thanks very much. Lucky last is always a challenge to bring up the end. It was interesting, those last two talks. No matter how hard I try with the first talk, I still find it creepy. And anybody else, I just try really hard not to, but it is. And then with Jared, I think that's really interesting. I mean, I think in terms of changing roles, I actually had a cardiac ablation myself for atrial fibrillation about 5 years ago, and just saw the kind of role of the interventional cardiologist. And interventional radiologist is part of that team, and it's kind of quite impressive to see that, how those roles are changing. And I think in the US, interventional radiology is one of the fastest growing and best paid disciplines. So I think it's kind of an interesting take on that. So I think I'm kind of circling back around now. I don't have many great videos and stuff like that. I hope I can keep you entertained for 10 minutes or so. But I really want to talk about something that Richard raised actually during that debate with Jason earlier about, I mean, what do we actually do about putting AI into medical education? So what I want to talk about is what do I see as the challenge that's setting up the AI may be able to actually help. Then I want to talk about something called practice analytics. It's something we're setting up as Jason and I are actually having a meeting in Boston in about 2 weeks' time around this. It's a kind of a new little discipline that we're starting to establish. Then talk about AI on education assessment. Now, I must admit, I've done what a couple of the speakers have done and not really stuck to my title in my talk. I put education in with assessment because I think they're totally linked. I think it would be boring to talk for 15 minutes about trainee assessment and AI. I just couldn't think of something to talk for more than 5 minutes around that. So I've kind of expanded that to make it more interesting. And I do want to talk about the digital health CRC because that's a live thing that's actually going on in Australia. It's probably the biggest, I think it is definitely the biggest funded project at $112 million over 7 years, and a number of you are partners in that. So we'll talk a little bit about that. Okay, so my great friend and colleague Federico talked yesterday. We've been kind of joined at the hip for the last 18 months, riding the bid, then getting it. And I just learned so much from doing that. Actually, the funny thing is, my talk's almost all pictures. Federico's talk is almost all words, and perhaps that's why we get on so well. So for me, Federico took the kind of magic out of AI in terms of it isn't magic, and I think he blew away some of that fairy dust, and it really kind of came down to the fact that it's about your data. And I realised that's what I've been really trying to chase in my career as I've kind of gone through this medical education piece. It's about chasing that data that can really help us develop better education. So, you know, I first walked into the College of Surgeons in 1999, invited by Bruce Barraclough actually to develop basic surgical training online. And I've had a very long history with the colleges since then. And, you know, really unpacking that, I think it's fair to say at the moment, the professional development piece, particularly where I live, doesn't work terribly well. And I think this is something, obviously, the My CPD Home's helping to address, and this is something that's a real focus of mine. So as we go through this talk, that's one of the things I'm really hoping we can work on. In terms of online learning, which is a space I've lived in now for I don't know how long it is, so since 1999, 19 years, it's really, a lot of it is totally unevidence-based. Jason and I were talking about this the other day. What's the actual impact of online learning? So this is one way we're actually starting to push out into better education. I think some of it is just so boring, or a lot of it's really boring. And it's actually, I think there's a real dive pedagogically to the bottom with a lot of online education. We're not really trying to use it in a better way, and I hope I can just demonstrate how we can do this better. And the other thing is, I know, in particularly in the States, there's such anger out there about this mandated online education that it's really kind of sullied the whole lot. And so if this was a conversation in America, everybody would be nodding their heads. So I guess there's some of the parameters I'm working on. The third piece that I've really felt over the last 20 years as I've been going around is I do think we've got these breaks between our professional practice, our quality improvement. I've done a lot of work in quality improvement over the years. I think we've got a break with our professional development. We really don't link these together very well. I don't think we link very well into assessment. Obviously, workplace-based assessments, trying to make that much better. I sat on the IMG Interim Accreditation Committee with Richard for 7 years, I think, trying to get the IMG Mini-CX workplace-based program up, and I think that's come some way towards that. And then obviously with the whole regulation piece about how this all fits together. I guess my premise is that I think having access to much better information and practice data and analytics is one way of actually starting to close some of these loops. And that's really what we focused on. So practice analytics was actually coined by somebody who's becoming a good friend, Rodrigo Cavalcanti, that many of you would know from the Canadian College, a really nice guy. It's a shame he's not here. We must get him here one year. So we were just chatting and we're saying, how can you take learning analytics that's got a lot of emphasis that's happening at the moment? I'll talk a little bit about that and start to add practice data into it as the premise of what we're looking at. And it's about making it kind of personalized. So I was reflecting on what can AI do, and I think it's that kind of personalization. And in fact, AI doesn't do anything. I mean, it actually just enables certain things. I think that's something we need to say. AI actually enables something to happen. So yeah, learning analytics. So there's a number of workshops that have been run in learning analytics at the ICRE over the last 3 years, and it's been really good. This is one of Eric Worm's slides that Jason mentioned in that talk. So I don't expect you to see the detail, but Eric's got this really nice way of now analysing, using algorithms about how trainees are tracking it, but it's just with assessment items. But it's really nice. He can start to predict when somebody's going off track and so on. So Eric's kind of a linchpin in this piece of work. And we're working with Eric to say, now, how do you start to layer over that different forms of data? So one of the first things I thought was, well, what do we know about our young clinicians? What do they actually want to know about their data? And very few people have actually asked them. So I ran a qualitative study. It's about to be published in the MGA, I think. So we ran it with mixed teams, and there was actually, so how many trainees are in the room? Great. So there was a lot of enthusiasm for getting the feedback, and then there was really a major piece about informative, not punitive. So there's something that came through really strongly, particularly in Canada. Actually, there's a real palpableness that they wanted this to be about formative assessment, not punitive assessment. There was a real desire amongst our young clinicians, so this was doctors, nurses, allied health professionals, to actually get peer comparison, benchmarking, and collaborative learning. They really want this. They also they raised a whole part of challenges, not surprising, so around data access and usage. And then some of the key pieces that came up that we've been looking at is, whilst we get much more data around each, I kind of look out at a room of clinicians and I see a cloud of data surrounding each of you, which is kind of related to your practice. Then if you've got a table of clinicians, I do a lot of work in oncology, suddenly all those data clouds kind of merge up. So how do you really understand a complex clinical narrative by having these different data sets that we're starting to emerge around each of our clinicians? So obviously there's work to be done. These were some quotes. Again, I've always been in co-design. I've been a self-funded academic for many years up until winning this $112 million grant. So I've always kind of gone where people want, so I always ask people what they want. So there's this, as I said, everybody wanted it. I particularly like this bottom quote, though. This is something that all the colleges have to deal with, I think, is as we start to gather this data. There was one, I think it was a young anaesthetist who said, if there's a hint of a policeman in the room, I'm gone. Or all I'll do is put in what is the minimum amount. I won't make this fun for myself or anybody else. I'm just going to just do what you tell me to do. So we've got to find ways of making this more protected, and obviously giving that quite a bit of thought. So that led me to build a program of research, I guess, over the last 10 years, really, and I've just shared just a couple of examples of that as we go forward. So really looking at how do we start to couple clinicians' performance data with their education. So how many clinicians in the room have had feedback on their performance data? I always ask this one. Okay, so how many clinicians in the room, sorry, first up? Okay, and how many have had feedback? Okay, so it's about half. But how many of you had feedback that's actually been linked in a scaffolded way to support learning from that data? 1, 2. Okay, it's the first time I've had anybody put their hand up. So I guess this is what we're focusing on, is actually how you scaffold this information and make it useful. I actually think presenting data to clinicians isn't the best way to show them stuff. I actually spoke to the Chief Medical Officer of Flatiron, which is one of the new EMRs, and he said they'd spent $6 billion or something building dashboards. And he said all they worked out was the clinicians on the whole don't like using dashboards that much. They use them for a while, and then they drift away. So it's okay, there's a learning moment. So I'm kind of thinking, how can you actually couple the data with other things? And that's really what we're looking at. And then obviously down the bottom, what's the role of AI? So I was lucky enough to spend a year in Harvard Medical School in their Department of Continuing Professional Development, about 10 years now. And I actually met a young surgeon then who's developed this program called QStream, which is a micro-learning object. And this is one of the things that's lodged in my brain about how can we actually take an object that will allow us to link with data. In a typical surgeon's way, he cut away all the stuff with online learning that was crap, and this was what he was left with. And it's really just a very short tool of firing micro case scenarios at people in a repeating pattern. He's got some beautiful data around how he's changed practice just from doing this online program. He uses the spacing and testing effect. My first study I did there is the bottom left, where I had all 800 of the interns coming to Mass General and Brigham. We used the course and showed a very significant impact on their ability in a blinded simulation to be safe in how they're asserting a central line. So the sorry, that's great after today. Sorry. Yeah, I lost my train of thought there. One of the first things we started to look at was how can we start to put feedback data from performance into scenarios. So what we actually did was, with 600 nurses across 3 of Brigham's big hospitals and Mass General, we started to say, well, can you take a course and actually drop feedback in it? So we took the Q-stream courses and we actually I worked very closely with the safety and quality department, and when something happened in the hospital, we abstracted that and turned it into a case overnight and sent it round to all the nurses. Which was nice. It ran over 3 months, and we also did courses around or cases around the National Patient Safety Goals in the US. And it was really interesting. It was a really well received course, and it has a whole gamification platform. So it had all the wards in the hospital competing with each other, which I think is another whole thing we won't go into now about medical education. But the gamification was a major part. And that's one of my favourite quotes of anything I've done in my research. It was the most talked about educational activity in the memory of the hospital leaders. And in fact, the most vicious competitors were the nurse unit managers in each of the units. And we gave them all acronyms, like band acronyms, and they just loved it. And they all knew who was kind of AC/DC. Actually, one thing I learned was never get a 40-year-old man to pick band names when all your people are 20 that are doing the program, because they didn't actually know the name of the bands. And then I traditionally give a boomerang now whenever I run a course in the States, and they love it. So that's gone on to work in Australia now, where we did a program where we had looked at improving pain scores at St Vincent's Hospital in Sydney. And again, just using this Q-stream course in a competitive environment, putting audit and feedback data at the unit level into the feedback of the program, we actually had a massive increase in improvement in pain management, and nearly a 2-point improvement in pain scores. And that's 2 points in the pain scores, a pharmaceutically relevant increase. So obviously there's something going on here if you can start to build these things together. That's now gone to a pilot we've just finished. I've talked to some of you about this. We ran this in Westmead just after Christmas in early January, where we started to say, okay, well, how can we start to pull things out of EMRs now? So what kind of data sources can we draw from about our young doctors so that we can start to make education much more temporal? I think sometimes in medical education we kind of give up the adult learning principles at all, about making it about what they're doing, making it linked to practice tightly. We still take a kind of undergraduate approach to how we teach people often. So we ran a program. We had a fabulous ED doc who wrote 60 cases for us on things that were commonly encountered in the ED department. We did an extract of the EMR every night, and when a junior doctor, we pulled out, I can't remember the exact data point we ended up on, but it was a data point that gave us the most accurate picture of what somebody had done in that evening. And then we sent them a case, a micro-learning case, within 12 to 24 hours of that happening. And then we'd let them ask for more cases if they want them to explore. We weren't at this point making any judgment call on whether they did a good or a bad job, just that we know you'd looked at a fractured cervix or whatever it might be. So that's gone pretty well. So we're now moving on to medical oncology. So we're working with our medical oncology colleagues to start to say, in registrar training in this, what are some of the key points that you can learn from that we can start to feed data back? And then ultimately where we're going, I hope in the next 6 to 12 months, is to start to actually put some audit and feedback data at the back end of those learning cases. Again, really simple, but we've had a really positive response to this from people we've talked to. So, just last couple of slides. I can take 2 minutes of your bit, Jason. Is that okay? Your summary? Yeah. So I guess one of the vision we've been talking about with a number of our partners and colleagues is obviously we've got this massive practice going on in multiple disciplines. Flowing from that is tons of data. So we've got lots of different data points. Obviously, the EMR on the left, we've got in Australia, we've got Medicare data, we've got registries data, PREMs and PROMs. Obviously, I think one of the key learning point data points that we're just starting to work on. Insurance data, so we've got all this claims data, which actually gives some of the best data, particularly around surgery, most accurate. Then we've got assessment, and then going right through to complaints and registry kind of data. So we've got a range of data that's flowing from this. We're starting to say, can you kind of analyse and understand that? So how do you actually really understand what all that data says about a practitioner? So we're just at the beginning of this journey, maybe like in the analogy of the kind of 3-year-old. Then obviously there's opportunities to apply AI to that. So how do we apply artificial intelligence to that to look for patterns and understand that better? And then how do we generate really punchy, personalised, information-driven, high-impact learning at the coalface? So I think we need other, I'm not saying we don't do grand rounds and we don't do conferences and things like that. Well, we know that in a conference you don't learn anything, change your practice. We've known that for a long time. But we still do other activities. But I really want to have this kind of coalface-driven learning, which then ultimately should link with continuous quality improvement. So that's what we were trying to do in Boston, was to make this part of the CQI kind of process. And then, I mean, ultimately, I don't see why this can't feed the new framework or revalidation, as you're calling it, in New Zealand. So I would think if you've done this should make up a component of your revalidation. If it's based on your practice, you've looked at it, you've worked through it, you've achieved that, then why shouldn't that be part of what you're doing? I do have my little flying pigs on that, but we'll see. Maybe I can be, it might come true. So, I mean, one of the great challenges, right, I was talking about my physiotherapist earlier in the last session about him being my favourite practitioner. All the information about my joint problems since I was 22 live in this filing cabinet. So totally inaccessible. So if I want to ask him about anything, if we want to use that data, this is where the rich data lives about me and his interaction with me. So this is a real problem. He only let me take the photo if it was fully de-identified, and I said I'd never mention his name, although he's my gold star teacher, and practitioner and teacher, actually. And then the thing I loved was he said, if I don't see him for 2 years and he moves them into his loft, then he says occasionally during winter he burns them. So it's like, oh my God, it gets even worse. So they disappear entirely. So that's something we've got to deal with. I think the other really big thing for you as colleges and regulators and others is this tension we got between performance and performance management. This is a real problem. This is what the trainees were really worried about. Because obviously the kind of people that are getting this data are people that can control careers, can control lots of stuff. So how do we manage this? I mean, clearly we've got different data points that drop in along that pathway, but somehow we have to be able to manage this tension. I'm much more interested in I think this should be for good, not evil. I'm much more about keeping it down the left. I think we need to build systems that are owned ideally by the trainees and the clinicians as they move through their career. I think we need to have that ownership, but then we have to manage this piece about as we're getting live data, we're understanding practice, what do we do with people that are poorly performing outside of boundaries? So we need to find somewhere around that. So obviously it gets this tension between education, remediation, and investigation. So how do we manage that? And I don't really have the answers yet. I think it has to be in some of the ownership piece for the trainees and others coming through. But this is something we really want to research. Okay, so just to finish up, I just got a couple of slides on where am I seeing AI in the actual education piece? And I was madly Googling when I realised what the talk title actually was yesterday about where's AI really impacting on education. So I think one thing that's kind of obvious that Federico raised was kind of NLP, natural language processing. Right? So let's just take out a whole part of administrative stuff that's really painful. Let's read the mini CX forms. Let's do them automatically. Why are we doing that manually? I think there's a whole pile of stuff that colleges can do that can save themselves a lot of time. I think clearly, anyway, the trainees, the young doctor, I think he's left unfortunately, that was talking about, of course they do this anyway. They're much better at accessing information than we were. I mean, I can't remember the last time I went to a library, but when I did my PhD, I didn't have computers, anything like that. So I think we can help trainees, although they maybe don't need much help. But in town, this whole information discovery in education is huge. I think in terms of analysing performance, I think this is going to be something that really comes up over the next little while. I mean, we know from Federico's and Enrico's talk, which was great this morning as well, the AI is getting, it's hard to interpret imaging. Obviously, I think the kind of laparoscopic imaging we know is getting better. So interpretation of those images is getting much better through to, I mean, that's a doctor in, I think it's an ED or an AMBO actually, using Google glasses down there, so they're recording everything they're doing. So I think we've got obviously technologies like that can record what people are doing and can be analysed. And then Alexa, we're playing with Alexa at the moment. Alexa can gather huge amounts of data around communication between clinicians and patients and so on, and we can start analyse that. So I think there's a real richness of data in there, and again, a whole part of ethical privacy issues that haven't been worked through. I guess the other thing is obviously the intelligent tutor is the other thing that's big in education at the moment in AI. So, and this comes back to not just passively giving information, but have a real interaction in terms of the feedback. And I think we can start to do better than this. I think Enrico and I are both showing our age by having Hal on the screen. I thought somebody's got to put Hal up. There's probably young trainees that don't even know who Hal is, but anyway. So, I mean, I'm not sure about the Brave New World we saw after tea in terms of those. Again, just creepy. I've never had a doctor say that's what I'm here for to me either. I think that's a fail, straight up. But I think we'll get to the position where we probably do have more, really much better intelligent machine-driven feedback systems. So finally, I thought I'd end with a slide, and I have to credit my wife who's in the audience about this. Tim, she was saying, why don't we think about something like Netflix or something like that? And I thought, this is a really nice idea. And I was chatting with Jason last night about this curve of education and training that goes through from when you're young to when you're perhaps more in the latter part of your career, and the arrows there are really kind of education recommendations that could be made to you. And why don't we use recommender software? There's lots of different things we can use here to actually start to tailor the education that's been delivered out, ideally based around your performance and so on. And that can link to your CBD home. Obviously, when you're younger, you need more scaffolding. As you get older, perhaps you need more scaffolding too. Maybe you need to look at cognitive function. You need to look at, are you up with the best guidelines? That type of stuff. Then I was kind of thinking, well, if it's Netflix recommended, again, showing my age. So for the younger crew, when I was 20, might have been Friends, Game of Thrones for people in the prime of their career out doing battle. And then I couldn't think about older people, but I thought of Father Brown. But my 12, anyway. And my daughter and I actually love not the middle bit. Nina's never seen the middle one. She's only 12. But she loves both of those sides, so I think I'm being ageist straight away. And then I was thinking, obviously that relates perhaps when you're a young doctor to, really intensive scaffold training, lots of hands-on work. We know that works really well. And then I think I was really, I liked that simulation talk that was earlier on. And I was recently in Queensland where they've got their IEMR embedded into their sim centre. They're bringing people through. They're actually simulating the EMR as part of the sim stuff. So I think that's obviously we've got that type of learning. Through to the the more mature kind of piece, where I think often it comes down to MDT teams and things like that. Obviously, we've had a lot around that. So it's actually what's the role of peers and others in educating and maintaining currency of practice. So just the last 2 minutes. Digital Health CRC, ridiculously big grant. It's on in Australia at the moment. We got funded 6 months ago, 110 million, all the jurisdictions other than Tasmania. Surgeons and physicians at the moment, we're very keen to add other colleges to this. So we've got private insurers, tech companies, 16 universities, which I always joke is 15 too many, but I just have to deal with that, that's my cross. I'm Director of Research for it and Federico's Chief Scientist. We've created a series of flagship programs. This is one around transparency, understanding clinical practice, transparency. So this is one very directed at you guys. How do we understand this? What are the tools and resources we can build around this? We've had a lot of conversations about digital capacity. So I've got a substantial budget to look at digital capacity. So I want to work with all the colleges around that. We've recently developed the eHealth capability framework. We're very happy to share. And just the last slide, I really hope you want to join in this journey. So if you happen to be in Boston in 2 weeks' time, you're very welcome to join us at Partners Healthcare. Might be easier for our Canadian friends. And so we're running the inaugural practice analytics workshop. hosted at Partners. And then next year, if you've got the chance to go to Ottawa, we've got a Bending the Curve pre-conference workshop looking at learning analytics and practice analytics. So I'll stop